Hello, everyone. Thank you for joining us today for a special World Bipolar Day presentation. In honor of World Bipolar Day, we are bringing it back to the basics in an attempt to promote better education and understanding of bipolar disorder to reduce stigma. I invite you to learn more about how to participate in our anti-stigma social media campaign for World Bipolar Day after this presentation on our website, www.ibpf.org. or any of our social media accounts where we are encouraging the use of the hashtag #BipolarBrave to share your story. Anyone tuning in on Facebook Live is invited to share directly to their own Facebook page. At the conclusion of this presentation, if time allows, we will be opening up for questions. These can be submitted through the Zoom chat or Q&A boxes, or if you're tuning in on Facebook Live, the comment section. I just want to have a little disclaimer here. I apologize if you hear any barking. I am working from home, as many people are right now, and unfortunately my four-legged coworkers do not always appreciate the need for silence, so I do apologize for that. Anywho, our presenter today is Dr. Candida Fink, a board-certified child and adolescent psychiatrist specializing in several areas, including mood and anxiety disorders and dual diagnosis of developmental disabilities and mental illness. She treats children, teens, and young adults with a range of concerns, including ADHD, anxiety disorders, OCD, autism, pediatric mood disorders, and mental health issues in school settings. Dr. Fink has co-authored 2 books, The Ups and Downs of Raising a Bipolar Child and Bipolar Disorder for Dummies. She has been featured nationally and locally in broadcast, print, and online media coverage and is a frequent speaker on mental health topics for community and school-based audiences. Dr. Fink is a veteran of the military, proudly serving the U.S. Army Medical Corps through the Massachusetts National Guard and the Federal National Reserves from 1985 to 1993. She received an honorable discharge at the rank of captain and is a member of the American Academy of Child and Adolescent Psychiatry and the American Psychiatric Association. We thank you so much for joining us today, Dr. Fink, and we look forward to your presentation.
Great. All right. I think that's my cue. Thanks to everybody for being here. Thank you, Aubrey and International Bipolar Foundation, for inviting me. I'm excited to be a part of this on this World Bipolar Day. I think that we're going to go back to the basics, of course, but I think it's really important that we stop for just a minute and acknowledge the times that we're in. So I have this PowerPoint, and hopefully it will just be a way to guide the conversation a little bit. So let's see where that takes us next. Okay, so these are just some important things I like to say before any time I give a talk. I have no financial conflicts of interest. I don't work for anybody else, actually, just me, and not invested in any drug companies, anything like that. As you will hear from most doctors on social media, the following is educational material. It's for education and information. It is not medical advice. For medical questions, I refer you back to your own providers. Before we start today, I want to make sure that you know that if you are in crisis or feeling suicidal, that it is important and okay for you to reach out for help. Start with someone on your team, your doctor, your therapist, your family support team, or of course, our national crisis line at 1-800-273-TALK-8255, or the crisis text line, texting home to 741-741. All right, so that's our starting point. Okay, so as I was putting this together, I really just wanted to start by sort of checking in with everyone. The COVID-19, the pandemic, all of the interventions going on right now are in so many ways completely contradictory to everything we talk about in terms of recovery and managing bipolar disorder. So this list of things that we are obliged to do right now to help flatten the curve and stop the pandemic: social distancing, staying at home, being in close quarters with people that may be very difficult to be around. Our stress levels are up. We're worrying about the health of our loved ones and ourselves. If we have children and they're home and now we're having to figure out how to take care of them or homeschool them, financial worries, food worries, trying to get to your doctor, your therapist, keep a supply of medication. So all things that we interfere with the day-to-day management of bipolar. So I think and have found in talking to my patients that this is an especially hard time. It's hard for everyone, but there are unique challenges in going through this and living with bipolar disorder. So I just want to make sure that everyone is taking their own emotional pulse, checking in with the people they love and who take care of them. And so that question is, how are you coping? And we'll get back to bipolar, I promise, but I really just wanted to make sure to spend a minute here. I love Ruby, etc. This is a cartoon by her. She is just this remarkable cartoonist who has such a knack for capturing the struggles and the victories and the challenges and the humor in living with mental illness. And I encourage you to find her work. But some suggestions before we start that I'd like to just bring up that I think may be slightly different than what we're hearing in the lists and lists of things to do with all our time and projects to do and food to cook and things to do. Most important thing I want everyone to really, that I would recommend and try to remind myself, is to use kind words with yourself. This is a really hard time. No one's got it right. There's no manual here. Be kind to yourself. It's okay to not be okay. It's okay to not to get things done. It's okay for your kids to not get everything done. You are not going to be the same as school. It can't be. This is a once in a lifetime thing. Do your best to get through, and sometimes you won't be able to do very much, and that's okay too. Make sure to sleep enough. Of course, we talk about being awake during the day, sleep at night, try not to oversleep, try to have a little bit of a cycle and regular time for waking and sleeping. But if you need to rest, rest. Eat enough. Don't restrict. Don't try to diet. Don't try to put in new eating and exercise plans. Take care of yourself. Move your body. Eat what feels and tastes good and nourishes you. And of course, do whatever you can to build in a schedule to remember to take your medications. And if they're not working, make sure to reach out to your doctor or your provider. So in the interest of self-care, I don't know why I picked a panda. I just think they're cute. Sometimes for my own breathing, I like to watch the Panda Cam from the National Zoo, but I couldn't figure out how to put that here. I'm not that technically savvy. So I found a picture of a panda. And one of the easiest things you can do to help relax your muscles, your brain, slow you down, is just counting 5 to 10 breaths. Don't have to do special breaths. Don't have to hold it or count it during the breath. Just reminding yourself and paying attention to your breath. Just even as I'm speaking, I'm counting 1 breath, and you might feel a big breath come on, and that's the second, just because you're thinking about it. The 3rd breath, there it is. And just in paying attention, your muscles will relax. You'll slow down a little bit, and it will focus you into the present. That's a 4th breath. I'll take a big 5th breath before I speak anymore. And there we go. And I hope everybody's ready to move on to our main topic. Okay. All right. So here we are. We're going to talk about bipolar disorder. I'm going to try to fit in important information in a timely way. I'm going to focus on sort of what bipolar is, how it's diagnosed, and broad strokes about care and management. I will briefly touch base on medications, sort of just the families of medication and a few medication names, but a talk about medications is completely different and would take multiple other visits, multiple other Zoom sessions. So we can come back to that another time. So I just wanted to let people know in advance that it won't be a detailed discussion about each medication. We wouldn't have time for that. So bipolar 101. What is bipolar disorder? Just jumped ahead and I don't exactly know how to go back, but that's okay. Oh, there we go. There, figured out. small victories. What is bipolar? So we're going to talk about what is the diagnosis of bipolar, what does that mean, and how it's diagnosed, how do you get that diagnosis. We'll talk about some of the components, the mania, manic episodes, depressive episodes, a little bit about what we know about causes, which is, really not a lot, but some general ideas. And we'll talk a bit about overall treatment and management. Take-home messages sort of across all of those topics. I think one of the most important things, and especially as Aubrey was talking about at the beginning, that one of our goals here is reducing stigma. And it's important to realize that bipolar disorder is a real disorder of the brain. I even hesitate to use the word real. Of course it's real. Anyone who lives with it knows it's real. But it's a brain disorder. There are changes in brains and brain circuits. Neurologists work with muscle changes and sensory changes and pain and that kind of thing that come out of brain pathology. Psychiatry, brain is an organ system. The symptoms of mood, thought, and behavior changes are our territory. That's what bipolar disorder relates to. And those are our symptoms that are affecting this big organ system, the brain and the nervous system. Okay. Anyone listening, I'm sure, will agree it affects many facets of life. It's a complex layered disorder. It affects families as well as the person living with bipolar. It is a chronic and manageable condition, and your team is key to your success. And by team, I mean you as the team leader and your family and loved ones and your professional care provider. So the team is a big group. All right, what is bipolar disorder? Sounds like a very basic question. So as I said before, we're talking about symptoms related to brain function. Those symptoms in bipolar disorder are symptoms of mood, thought, and behavior. So sometimes we think of bipolar disorder as it's called a mood disorder, so we think just mood, but it really affects our function in primarily 3 different domains: mood, thought, and behavior. It comes in cycles or episodes, and the symptoms during those episodes, the changes are notable and they are sustained. So we have cycles that are notable and sustained and affect mood, thought, and behavior. Just to touch really quickly back on notable and sustained, these are changes from baseline. In other words, you're not yourself. They're notable. Often that means they can be seen by others. They change your function. They change things in your life. They are visible, notable changes. And they're sustained. Symptoms of mania, symptoms of depression typically last weeks to months. We'll talk a little bit more detail in a couple of minutes. So how is bipolar diagnosed? So now we know what it is. It's this cycling disorder of episodes affecting mood, thought, and behavior. And how do we get to that diagnosis? How do we find out what's going on? Well, primarily, it's a psychiatric evaluation, which involves a meeting with a psychiatrist where they'll take a history, get information about past mood episodes, current symptoms, any health issues, substance use issues, coexisting. If the psychiatrist feels it's important, they will also ask about your medical history, and they will look at medical and neurologic evaluations if they need to, any lab tests or consultation with neurologists or brain imaging, only if needed. It's not typical, but in some cases we may want to. And then we're going to dig deeper and understand what the manic symptoms are that would come together to create a manic episode, if that's present. Depressive episodes made up of depressive symptoms, we want to see if that's present. We're putting those pieces together through the history and then through our conversation, called a mental status exam. You're sitting in the office while we're talking, trying to understand how you're thinking, how you're speaking, how you're moving. All of those things are going to be important to my making that diagnosis. So that's how we start. We're thinking about bipolar disorder, and I wanted to briefly mention that there are really 3 different kinds that we're going to talk about today. Bipolar type 1 is the one I'm going to spend the most time. There's bipolar 2, which we'll talk a little bit about. And then what we used to think of as mixed episodes, depression and mania together, but are now referred to with different terminology, either manic episode with mixed features or depressed episode with mixed features. But these are kind of 3 big categories that I wanted to just lay out for us to think about going forward, so you have an idea of the general structure that we're looking at when we're talking and making a diagnosis of bipolar disorder. So the key thing to remember, bipolar disorder type 1, you have to have a manic episode to make that diagnosis. That is the key criteria. In the US, that's all you need. Most people also have depressive episodes. However, interestingly, in the US, that is not required. You can have bipolar disorder with just mania. Very rare, does happen. In Europe and other countries, their diagnostic system requires at least 1 depressive episode. This manic episode has to happen not because of substance or intoxication or medication causing these changes. It has to be existing on its own. And it has to not be happening because of a medical problem, such as a stroke or other neurologic kind of disorder. So when we're thinking about a manic episode, for example, or a depressive episode, we are talking about 3 domains. I think I mentioned this before. We want to look at changes in mood, changes in thought, and changes in behavior. Those are the features that are going to give us, bring us to the diagnosis. Now, what are symptoms versus episodes? Those terms sometimes get used interchangeably, and I think it's important in thinking about the basics to sort of be clear what those are. You can have a manic symptom, such as very high energy, but if you don't have several other symptoms together, it's not a manic episode. To meet that criteria, to make that diagnosis, you need to have a certain number of symptoms, and that's spelled out in the DSM-5, our diagnostic manual. The symptoms have to last a certain time, a certain duration, and the symptoms have to affect function. So an depressive episode, you might have low mood, slowed thinking, but it has to last a certain amount of time, and you need 2 or 3 more symptoms to call it an episode. So symptoms versus episode. And again, we come back to that very basic point. You must have a manic episode to be diagnosed with bipolar type 1. Manic episode. Manic symptoms that affect mood, or how mood presents in a manic episode. The most classic and common, and certainly what we see in the movies or in TV, is euphoria, sort of this beyond happy, disproportionately happy compared to circumstances. That is not universal, but it is certainly a common part, especially at the beginning of the episode. Irritability is also very common. The diagnostic counts of symptoms are a little different if it's only irritable. So euphoria is a pretty central feature, but again, it can happen without. I put anger and rage separate from irritability because that's another whole level, but certainly can be part, sort of next level of irritability in a manic episode. So euphoria is the most common mood state, irritability, and anger and rage. Now, these are mood symptoms happening that are a change from baseline, look different than usual. Thinking, manic symptoms that affect thinking. One of the most sort of classic symptoms are racing thoughts, or flight of ideas. Thoughts going so fast you can't catch them. Jumping from idea to idea, topic to topic. It looks very distractible to people you're talking to, sort of topic, jumping, something you think of, jump to the next. And people listening to you will note that your speech is pressured, coming out very quickly, and sort of like you have so much to say, pushing it out there, pressured speech. A major symptom in thinking in mania or manic episode is grandiosity. And this is sort of thought, the content of thought. And this can sometimes be a little bit harder to fully sort of flesh out and be sure that it's there, but in its most classic form, it is really a extraordinary self-confidence. Everything's great. I'm great. I can do anything. I can do everything. In fact, I'm going to do it now. Often what I find with folks when we're kind of building, it's sort of a sense of, I figured this all out. I have an answer, a solution. I put some points together, and I have these big ideas and schemes and people I have to talk to and things I have to fix. And so it's that element of sort of bigness and big charge to the thinking and the content of thinking. That can go into psychosis. We'll touch on that a little bit, but that grandiosity can lead to sort of delusions about that thinking that is so far disconnected from reality that we would call it a disordered thought or thought disorder or psychotic piece of mania. Manic symptoms and behavior. These are things we see, the symptoms in mania that are behavior. Decreased need for sleep, this is key. Not insomnia, not trouble falling asleep, but then exhaustion all day. The next day, I mean, that can happen, but the cardinal symptom is this high energy or high charge or needing less sleep. There's an increase in goal-directed activities, calls, projects, travel, all kinds of things. And many of those activities can veer into high-risk, impulsive, poor judgment kinds of behaviors that someone would not usually engage in, spending a lot of money, sexually very active and indiscreet, gambling, those kinds of things, impulsive, poor judgment, high-risk behaviors that can cause great harm to someone's life and relationships and bank account. So we talked about mood, we talked about thinking, and we talked about behavior. And the things that sort of pull these together to make an episode and not just symptoms are that we have a cluster. As I said, there's sort of counting of certain numbers that you need. And in mania, these to be a true manic episode, it needs to last at least a week, but that can be foreshortened. It can be less than a week if it is so intrusive in life that it leads to a hospital stay. Manic episode can include psychosis, most prominently delusions, paranoid delusions as part of those big systems, delusions of grandeur, believing that you have more control or more power in a situation, that kind of thing. Hallucinations, auditory hallucinations, hearing voices can happen. It is a bit less common, but not, it does happen in some more severe episodes of mania. Depressive episode. So we talked about manic episodes, all the different pieces, the symptoms, how it comes together to make an episode, and that is required for a bipolar diagnosis. Remember, depressive episodes are not required, but very, very common. Bipolar depression usually lasts longer than mania. Mania is often on the order of weeks to months-ish, commonly. Depressive episodes can last more on the order of months to years. Depressive episodes, because they're longer, and can be quite severe, often have more sort of chronic and persistent effects on function, and can really cause some of the most extreme functional problems from bipolar disorder. The symptoms look the same as unipolar depression, people who have depressive episodes, but they don't have the manic pole, but it looks the same. We're going to go through some of those symptoms, and they're very similar. But what we do know is that their responses to treatment are different. And so for that reason, we think they are not exactly the same neurologic element. They're not quite the same. They don't respond in the same way. And so treating bipolar depression has its own very unique challenges. Coming back to what we talked about in mania, same themes. A depressive episode is a change from baseline, a change from your usual self. It is notable. The differences are significant and affect things, and often can be seen by people around. Although, of course, in depression, a little more so than mania, people will hold on for as long as possible to keep their difficulties to themselves, often to be covert about it. So it can be longer until it's seen or noted by others. And sustained. And as I said, this is often longer, weeks to months, months to years, as opposed to necessarily weeks to months. Mood symptoms of depression. Sad mood most of the time. Again, sometimes people can be very good at hiding that, but there is a sadness, darkness, irritability, anger, absolutely can be a symptom of depression. Dark cloud, while it's not exactly a mood, but I think that captures what I often hear, what many people describe about the sort of mood of depression. So again, that mood disorder, key component, sad mood, irritable mood, dark cloud. There can be a sense of apathy, of not caring, and that can be sort of a variant of depression. But in the diagnostic criteria, we're looking for something in sad mood often, but apathy and not caring can be a big part of it. Depressive symptoms in thinking. Depression affects your thinking very much. Focus, concentration are disrupted. Your cognitive defaults, the way you think about the world, become defaults, are very negative about yourself, about the world, pretty much so much that you see or take in, even if it's pretty neutral, be seen or processed as negative, bad, dark, hopeless, helpless feelings, guilt and shame, blaming yourself for so much, feeling terribly ashamed of yourself. Suicidal thoughts are, of course, something we think of in depression. They are common. And I again urge you to go back and speak to someone in your life. If you are having suicidal thoughts, please let somebody know. Slowed thinking, slowed speech, part of the effects of depression on our thinking. Effects on our behavior, depression. Low interest or pleasure, it's called anhedonia. Things that used to feel good don't feel good anymore. Gardening, knitting, reading a book, sex, spending time with friends can all start to feel more just not fun, not interesting, don't bring pleasure. Low energy. Sleep changes can range from terrible trouble sleeping to sleeping all the time. Often sleep feels ineffective, so you can sleep all the time and still be tired. The biggest difference from the sort of separating this from mania is that it's sort of the low energy, the low charge. Appetite changes can go to increased appetite or decreased appetite, weight loss or weight gain. Social isolation, pulling away from friends, family, the world, and slowed movement. Just like we get slowed thinking, we can get slowed movement. So again, mood, thought, and behavior. Mixed presentation, I talked a little bit about before. We get depressive episode with manic symptoms, so someone who's very sad, but their brain is racing, they're feeling very agitated, or someone who's can't sleep at all, very high energy, but is horrifically despairing and sad, so that kind of thing. So you can see these mixed presentations. We don't call it a mixed episode anymore, but these can be particularly challenging to diagnose and identify. So that's bipolar 1. A manic episode is needed. Often people have depressive episodes affecting mood, thought, and behavior. Bipolar 2, I'm not going to talk in too much detail, but just to describe the difference. It's not as well studied, but it's very common. It is much more the story of a chronic, persistent sadness, chronic, persistent depressive episodes coming and going, more often time in depression than not. Definitely affects function, reduces function, affects how you feel every day, most days. In between, there can be episodes, what we call hypomania. So hypomania is high energy, strong concentration, interest, super focused, stuff that feels really good. And in fact, by definition in the DSM-5, hypomania, hypomanic symptoms do not interfere with function. They're actually often very high functioning periods. And so very often we don't hear about it. We have to really be sure to ask, because most people won't tell us, well, hey doc, I had this time where everything was great. I thought you should know, because it doesn't feel like there's something wrong. But in the context of a pattern of this depression and then these spikes, that's really important for us to know, because that will affect how we think about things, how we treat things. And if you have hypomanic episodes, even though they are great, they do spell a higher risk for eventually having a full manic episode. So that is really the story of bipolar 2. We're not going to really talk about treatment, because there's different approaches to it, and the research is a little different, but we'll sort of put a pin in that for now. But to know that it looks different, but it still has this cycling quality to it. So here's something I'd like to spend a few minutes on: what bipolar disorder isn't. I work a lot with children, and this has been a big conversation in the world of child psychiatry, but it is also discussed in adult work as well. There are people with chronic baseline irritability. They are irritable and angry much of the time. As children, they're irritable and angry often, if not all the time. They have intense reactions to triggers, temper tantrums, explosions. Their mood can change daily or hourly, usually based on a trigger. Not always, but often. Those symptoms themselves are not enough for bipolar disorder. Those are not a manic episode. The meltdowns or the intense reactions or the chronic baseline of irritability, that does not make a bipolar diagnosis. First of all, it is not episodic. There's episodes sort of up and down around this already irritable baseline, but it's not a big spike and a little spike, or big spikes that last. Now we'll talk about it in a minute. You can get bipolar overlaid onto this, but these alone, this presentation is not bipolar disorder. So we think about, between episodes, bipolar disorder is a diagnosis of episodes, manic episodes, depressed episodes, mixed episodes. And what's it like in between? Sort of, is there a space where we feel okay? And so I want to think a little bit, just for a minute, about that. It's really a range. There are people whose between episodes moods are what we would call euthymic. Typical ups and downs, no particular depression, no particular manic charge or manic mood, euphoric mood. They're just even. They really come down to a full even place. And that can happen. We definitely a subset of people with bipolar disorder where that is absolutely the case. There are people who are more irritable and reactive in between episodes, like we were talking about before in the last slide. There are people who are sort of hyperthymic, sort of these not overly, but no judgment. They are sort of highly sort of ebullient and happy at baseline. And then people who are more sort of chronically down or sad or dark, and we would call that dysthymia. So mood between episodes really runs a full range. Doesn't have to be any one way or the other. Mood changes, between episodes behaviorally, again, a range. Some people are very hyperactive at baseline. These are sort of hyperthymic energy versus a sort of more depressive, low energy vibe between episodes. Baseline impulsive, poor judgment on the sort of more manic type of between episode presentation versus the more depressed inter-episode, sort of trouble doing anything, trouble getting anything done, having, trouble generating activity as opposed to doing activity impulsively. Inattention, distractibility can come kind of across the board and is fairly common for most people with bipolar in between episodes, not all, but many. Executive function challenges, another conversation for another day, but inattention, distractibility, that kind of thing is very common. And again, just the parallels come back up between episodes, thought patterns. People may be sort of high pressured speech people. They're always putting things out there, even not in an episode. During an episode, it gets worse. Or people who are sort of more slowed and sort of take their time in speaking, and again would get much slower when they're depressed or much faster when they're manic. Busy brain, rapid thinking, sort of people who are jumping all over the place versus slowed thinking. So again, the full range. And then again with ideas, big ideas, to trouble even having ideas, trouble thinking of things to do. It's more depressive tone. So the between episodes can really look very different from person to person, and are not the diagnostic component. The key diagnostic components are the episodes. Okay, so that's what it is, how we diagnose it in the office, what we do. And this, I just want to spend a minute thinking about what causes bipolar disorder, because that's a great question. We want to know it. Okay, you say it's a real brain disorder, but how do we get it? What does it mean? So one thing, the research is expansive and in so many different directions, and there is not any one answer, but there are a couple of important themes. I think it's important to sort of use the language of neural circuits. So parts of the brain communicate with each other. There are circuits that are mostly dedicated, say, toward protecting us. Sort of those are anxiety circuits, or circuits dedicated to pleasure and having fun, or circuits dedicated toward focus and attending to our environment. Myriad of circuits, and they speak to each other and they communicate with each other through nerve cells and packets, transmitter chemicals that send messages, and the signals between the circuits are important. So one circuit speaks up. I'll use one example, says, oh, there's a danger in the environment. I see this, it's a danger. And then the other circuit starts to read, it comes in through the eyeball. Oh no, that's just a shadow. That's not actually someone going to hurt me. And then they have to communicate back to the danger circuit. Okay, it's cool. We're not at risk. Now, those circuits, if their signals are too loud or too soft, that's a little cartoon-esque, but the idea that the communications are not working well and that the circuits are too active or not active enough, or are misfiring. Those are the areas where we are finding the most promise in terms of researching and understanding bipolar disorder. So I think I say that to try to move away a little bit from the idea of a chemical imbalance. I think that word is good. It was helpful to try to be clear that it's not just something that's not real. I think we use that language to say, no, it's a real thing. but I think the more sort of accurate way of understanding it is about circuits. The other major theme here is that it is clearly a combination of genetics and environment. There's not any one gene. There's a range of candidate genes, probably many subtypes of bipolar disorder, overlaps with other psychiatric illness. So there's much to be done in the world of genetics and how the environment interacts on those genetics. But that is ultimately the story that we will sort of be filling out over time to help understand more about what causes bipolar disorder. Take home message here is it is nobody's fault. No one has caused their bipolar disorder themselves, their family. It doesn't work that way. It's not a fault. It's not a failing. Just briefly, the science is complex to give you an idea of where people are looking. Imaging, brain imaging, they use MRIs, regular MRIs, they use functional MRIs, which tell us how the brain parts are using energy, sort of talking about those circuits, how active they are, how quiet they are. Those are functional images, functional MRIs, PET scans, those are some of the areas of research. There's all the genetic research and something called epigenetics, which are sort of chemical changes that affect how genes are expressed. And those run the gamut from chemical or medical exposures to stress. So things that can happen outside of genes but affect a person and affect how that person's genes are expressed or how their children's genes will be expressed. Biomarkers, that's the holy grail. We want to be able to do a blood test or do a scan that tells us, yes, this person has bipolar disorder way off in the future. That's certainly something people want to know about. Inflammation's a buzzword. Absolutely understand that in bipolar disorder, like many other psychiatric illnesses, there is inflammation. There are chemicals that suggest the brain is trying to recover from injury. That's what inflammation is a way the body recovers. It puts out chemical packets and chemicals that are trying to heal from injury. We know that's increased in certain ways in bipolar disorder, so we want to understand how that might help us know more about what causes it and eventually maybe some ideas about treatment. There's some interesting work on how the gut microbiome might affect bipolar disorder and the evolution of bipolar disorder. And the work in trauma is really important, and how trauma in life may affect the expression of vulnerable genes to bipolar disorder, and that kind of thing. So just some areas, and not at all exhaustive. Don't have a test yet, as I said, brain scan, a blood test. Particularly working in child, we find that we want to be able to predict. So we have kids who have a lot of temper tantrums, or kids who have depression or serious anxiety, and some percentage of them will eventually have a manic episode. So is there something we can see in how they present clinically, how we're working with them, what their symptoms are like, that tells us, oh, this child is more likely to have a manic episode later in life? And there are some kids who present with mania, but it is pretty rare before puberty and more often happens in the late teens to mid-20s. But is there something we can see in children that says, oh yes? And we have some ideas, things that increase the risk, but they are not in any way 100% predictable. Family history is one of the things, certain ways the depression or their behavior presents, but there's a lot of very angry children, kids with a lot of problems regulating their mood and their impulses, and the vast majority of them will not develop a diagnosis of bipolar. But is there a way we really, that's sort of our holy grail in child and adolescent work, is, well, how do we know, so we can treat them and sort of hopefully prevent it from happening or decrease the problems that they have from this disorder. All right, treatment. We think of three main components: treating mania, treating depression, and preventing episodes. Broadly speaking, I'm going to talk about treatments in sort of 3 or 4 different ways, primarily the first 3. So skills and strategies, people might call these lifestyle. I think that's a little just sort of blaming. It's not like you just choose your lifestyle to make these changes. These are skills and strategies that can help, can be very hard to make happen, but that we can work together to build as protective and preventive and recovery oriented. Non-medical treatments with professionals, therapies, and then, as I said, we'll touch briefly on medication and a couple of other things. So skills and strategies. Again, this list is anything but exhaustive, but these are some of the key things I work with my patients on, family members of mine who have bipolar disorder, mood monitoring, finding a way to sort of see those cycles so we can try to catch them. Sleep regulation, so important. Not becoming sleep deprived is an absolute bulwark against episodes. Food for health, and I speak very generally here, don't talk about diet or weight or anything like that. Those are complicated stories, but eating food that tastes good, enjoy your food, have social connection with food, food that is, works toward healthy body, healthy brain, but taking care of that. Stress management, all the stressors in life, and we can't make stressors go away, but how can we help manage and regulate and time and space, disconnect when we need to. Human connection, critical, not isolating. We often isolate, we're symptomatic, we don't feel well, pulling away, we don't want to tell or we're embarrassed, but human connection is key to feeling well. Exercise, I wanted to put a different word there, I forgot to change it. It sounds also a little punitive and gym classish. Move your body, walk, be outside, find something that feels good. Movement is a huge part of our bodies feeling well and our brains feeling well, but it's very individualized what that looks like, and finding what feels good to you. All your other health maintenance, take care of your heart, your gut, do all your preventive care. Setting boundaries, now human connection is important, but setting boundaries with people who are not good for us is equally important. So, and if you find yourself in relationships that are toxic or abusive, those are priorities to try to ask for help and change. Sorry. There we go. Therapies by professionals. Just, that you're going to bring a professional into, as opposed to the sort of more life type of interventions. There's many of them, again, not an exhaustive list. Something called interpersonal rhythm therapy, built specifically for bipolar disorder, which has some good research around it. Regulating your rhythms with people, balancing sort of how much time with people, sleep-wake cycles. Cognitive behavioral therapy primarily has excellent research in depression and anxiety, and can be a very important part of treatment. Dialectical behavioral therapy, focus on emotional skills training, interpersonal skills training, ways of managing big, difficult emotions, being able to get problems solved, get things you need effectively, tolerate discomfort. It's an outstanding treatment package that is used in a range of mood disorders. Interpersonal therapy, a very specific therapy for depression. Mindfulness-based stress reduction, also for depression and anxiety, based on mindfulness meditation techniques, very specific kind of treatment. Acceptance and commitment therapy, a subtype of cognitive behavioral therapy, working on sort of focusing on an acceptance of things that may not be able to change. Behavioral activation, that's the story of those low energy, trouble doing things, sort of being able to do. Being able to get up and sit up off the couch. If you can't get up and take a walk, sit up, stay up for a few more minutes. If you don't want to make a long phone call, dial a friend, talk for a minute, those kinds of things. Really trying to build some, because activity, it's a terrible terrible bind, because activity helps, the doing helps, but the doing is so hard when you're depressed. So that space is a real challenge, but a very specific focus of treatment. All right, medications. Again, that same structure, treating mania, treating depression, and preventing future episodes or reducing likelihood. So the first thing we'll talk about briefly is anti-mania. Anti-manics are someone in an acute manic episode, it's a medical emergency, and we need to slow that down and turn that off. Dopamine inhibitors, the antipsychotics, that family, most of you have heard of Abilify or risperidone or Seroquel, some of the newer ones, or Rexulti or Vraylar. Those are all work in the dopamine system, and inhibiting the dopamine activity helps to reduce mania, also helps to improve thinking, reduces psychosis. And those are a core part of our treating mania. Lithium is an acute anti-manic agent. Depakote, an acute anti-manic agent, and Tegretol as well, not used as often, has a lot of side effects. Trileptal is a sort of second generation Tegretol, has fewer side effects, but the data on how effective it is for mania is much more limited, so we don't know how well it works. Antidepressants, this is the biggest of challenges. They really may or may not work in bipolar disorder. There's plenty of data studies that show that they're not as effective. They may trigger manic symptoms. They're often, we get sort of antidepressant poop out, where it starts to work and then stops, and that's part of the bipolar pattern. So we do have medications that we use and try to use alone for bipolar depression. There's a medication called Symbyax, which is actually a combination of an antipsychotic and an antidepressant together, olanzapine and fluoxetine, which is Prozac. Seroquel, quetiapine, Latuda, a newer one that is very specific for bipolar depression, Depakote, lithium. These all sound, some of these sound familiar from the anti-manic. They also serve as antidepressants in bipolar disorder. Lamictal or lamotrigine, we haven't seen yet, that works, helps with antidepressant, not so great by itself, and also works, as you'll see in a minute, to reduce the likelihood of next episodes, but it's not an anti-manic agent. It wasn't on that first page. Prevention, maintenance, lithium, Depakote, the antipsychotics, dopamine inhibitors, Lamictal, Tegretol, these are all ideally, we would love to have someone on no medication, but if they have to be on something to prevent, we'd like to get them down to one. But it is, I'd say, fairly common that people with bipolar disorder end up needing a couple of medications to really prevent the future episodes from happening. I didn't put in a separate slide for psychosis, but psychosis can be a factor, can be an effect, can be a symptom in either mania or depression. And the antipsychotics become crucial there. If there are psychotic symptoms, then we must use the antipsychotics in addition to any of the other anti-manic or preventive agents, because we want to get that symptom regulated as quickly as possible. Other kinds of treatments, sort of brain-specific treatments, ECT or electroconvulsive therapy is a very effective treatment for treatment-resistant depression. Not as clear, but is used for mania that's not responding to something else, or for someone who is not able to tolerate medications. Transcranial magnetic stimulation, which is a brain stimulation technique. It is not intrusive. There's no anesthesia. It's done in the office. Usually takes about 35 sessions initially. They're half an hour to 40 minutes long, sort of a tingly sensation on the scalp, and it has some excellent results in treatment-resistant depression, unclear, really, in terms of specifically for bipolar disorder. Deep brain stimulation is experimental research for extraordinary depression, really still experimental. Ketamine's getting a lot of play. It's the first sort of new thing for depression. It works in the glutamate system, totally different neurotransmitter circuits. And has helped a lot of people much faster than other antidepressants, but it's still very early in its use. Side effects are very significant. And I think it's really a first step to medications in the glutamate circuits, but it itself is still somewhat prohibitive in terms of its use because of side effects. All right. Comorbid or co-occurring conditions. These are just a few: anxiety, extremely common substance use, OCD, heart disease, and other health issues. Both seem to be related specifically just to the illness in terms of that overlap with inflammation, for example, we think is part of why people with bipolar disorder have more heart disease. And then when we add medications, those can increase risk for heart disease. I didn't put ADHD up here, but there's a lot of overlap in these symptoms. but treating ADHD in bipolar disorder is complicated. But we want to optimize and manage other conditions, health conditions and psychiatric conditions, because it's going to be important in managing the bipolar to have those under control as well. So prognosis, sort of what does it look like? What does bipolar disorder look like in someone's life? When someone has had a manic episode, patterns of manic and depressive episode, the risk for recurrence does not go away. As I said, as we understand it, in most cases, it is a chronic condition and the risk persists. What we do know, what the data suggests, is that episodes that are not treated, that are left to resolve on their own, seem to make it easier for the brain to have the next episode. So it sort of lowers the threshold. So it's faster to episodes. And that's why we find it so important to treat and manage episodes, because the more episodes you have, the more you're likely to have. We can manage symptoms, and we can prevent episodes in many cases, big percentages, but it can be a challenge, and it really requires the whole team. And you are the team leader, and you have professionals on that team, and you have loved ones on that team, and it is an ever-evolving plan of addressing all kinds of things, but it's absolutely a manageable disorder. And we think of it as a chronic health condition. It's managed like other chronic health conditions that require this kind of vigilance and professional and non-professional supports and changes in life. You know, for example, not living near allergens if you have bad asthma and that kind of thing. So making changes and adjusting life, doing things to help you stay well, and people around you to help you do that and support you through that. Back to the take-home messages: real disorder of the brain, affects many facets of life. It's chronic but manageable, and your team, you as the team leader and your team is really the key to treatment success and successful management. I think I was talking to a patient actually just the other day, and we were talking about COVID-19. She's been in recovery for many years, and her recovery groups are a key to her sort of surviving so much in her life. And right now she finds it essential to her getting through the COVID-19, being on her own and quarantining, older person. And she was reflecting on lessons that she learns, that she's used, and she finds her friends are finding helpful now who aren't in recovery, some of their sort of shorthand. And I just thought it was worth, I thought she made a good point. I thought it was worth sort of bringing up here, in the sense of sort of living through something like this, which is really so different and so much stress when you're already trying to manage a chronic illness, and to know that it's okay to not be okay. Working toward accepting and letting go of what we can't control, which is really hard. Ask for help when we don't feel okay. Ask for help when we do feel okay. Stay connected. Ask for help in letting go. Talk about it. It's okay to talk about it. Whatever's going on, we put it out there. And the old saw, the old truth of one day at a time. And I know from my patients and myself, my own family, sometimes it's a second at a time, but one at a time. And I thought those were, just as she brought them up to me, I wanted to share them because reflecting on it, they made a lot of sense to me. And there's Cape Cod. And thank you very much for listening. I tried to squeeze a lot of material in here, and I know I probably went pretty quickly, but I think this will be in the library at the International Bipolar Foundation, so you can go back over it if you, for any reason, would find that helpful. I don't know if we left any time. I wasn't timing myself well, but if there's any time for questions, I think Aubrey, I think you're on it.
Okay, thank you so much. That was a great refresher for those of us with bipolar disorder, and for those of us new to the diagnosis or just looking for more information. There was a lot of info packed into this. I also want to thank you, Dr. Fink, for just taking the time for that guided meditation and for the COVID coping strategies. I'm seeing the Facebook comments that there are a lot of there's a lot of feelings of gratitude for those. I'm going to squeeze in a couple questions real quick.
Okay.
This question is regarding when women go through menopause. I'd like to open that up to women going through any hormonal changes, whether it's menopause or pregnancy. Do you think it's a good idea to see a doctor more frequently during this time? And is it true that treatment may have to change, especially with medications?
A great question. Being in that category myself, I can tell you that there's so much that changes and so much going on. And yes, our hormonal systems, whether you're talking, I'm obviously in menopause, not pregnant, but in pregnancy or menopause, or all of our sort of, big hormonal inflection points and shifts can change both symptoms, risks of mood episodes, and sometimes needing us to change treatments. So I think, keeping a close connection with your treaters and providers may need to be increased, or just increased communication. Being okay with speaking up and saying, hey, this is happening, and I need to know, what can we do to work on it together? And having a plan and building a plan. I think, women's complaints sometimes are dismissed a little bit as, just whatever, women's complaints. So I think, especially around hormones, sometimes we are dismissed a bit. So I think having support and encouragement, take someone with you to the doctor if you feel like you're not being heard. Take a list of questions. Don't be afraid to speak up, and be clear. And if you feel like you have ideas about what's going on and it's being dismissed, then seek a second opinion. Unfortunately, I think it's just a little too easy for women's complaints to be dismissed. So that's my little editorializing there.
Thank you. A second question is a clarification on cyclothymia and bipolar disorder. This individual wants to know, are they different disorders, or is cyclothymia a less severe version of bipolar disorder?
So yes, I mean, I left cyclothymia out because it's considered a relatively, rare diagnosis, although that may in fact not be true at all. It is not just bipolar disorder light. It looks a little more like bipolar 2, with sort of a sort of more steady depressive tone, with periods of increased charge and focus and energy and mood. The thing about bipolar disorder is that the thing about cyclothymia is that neither pole can meet full criteria. So in other words, the depressive symptoms can't be a full depressive episode, and the manic or hypomanic, the manic symptoms can't come together to be a hypomanic episode or manic episode. So, it's really a different, looking at something different. But just as I talked about sort of symptoms versus episodes, it's more sort of symptomatic, but there is this cyclic quality through mood states. So it does share that, but it doesn't become sort of these sort of medical episodes per se. And I don't think there's been anywhere enough research to sort of be able to say how that relates neurologically. But that's pretty much, it is really a different animal, I would say, than bipolar disorder. Similar patterns.
Okay, unfortunately, due to being short in time, I'm going to ask one last question, but I thank all of you who have just started putting questions into the box. I'm going to ask this last question, which is, do you know of any studies on childhood trauma triggering bipolar disorder?
There's definitely some research. I don't have a citation to give you right off the top of my head, but I can try to, you know, find some of the more recent, or find one that's relevant and recent, and I can share it with Aubrey. So, but I can look into that.
Okay, great. Actually, I'm going to ask one more.
Yeah, sure, of course.
What do you mean by somebody who is in recovery? What does that phrase mean?
So in recovery to me means pretty much living with bipolar disorder. So in recovery meaning not in an active episode, and living sort of in that space of managing, but not, and preventing, and taking care of, but not in an active episode. So that's I think how I use the term recovery.
Okay, great. Well, thank you once again. This was a fantastic presentation. We are so grateful to have you. We thank everybody for tuning in. And I
Yes,
just
thank
want to
you.
remind everybody that this has been recorded. It will be available on our YouTube channel. It will be available on our website, and it will be shared on our social media again. And so we ask you to keep an eye out for that, and to continue participating today in World Bipolar Day. As I said, you can go to www.ibpf.org for more information about sharing your story, participating in the hashtag Bipolar Brave campaign, etc. We hope that you all stay safe and stay well, and we will see you next time. Bye-bye.
Thanks, Aubrey. Bye.